Good evening. I'm Sandy Collier. Thanks for joining us for our 5-part series on opioid prevention education. Tonight is our final segment in this series. Dr. Brian Coleman will share with us his insights on pain management. And finally, a powerful interview with former Denver Broncos player Vance Johnson. He will share with us his struggle with addiction, from near death to recovery, to him now being an inspiration to others. This is an interview you don't want to miss. But first, a message from our executive director and our board president.
Hello, my name is Laurel Dalton and I'm the Executive Director for the T. Leroy Jefferson Medical Society. I would like to thank you for participating in our education series today, along with our wonderful expert panelists as well as the Health Council of Southeast Florida. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for the Continuing Medical Education through the joint providership of Florida Area Health Education Center Network and T. Leroy Jefferson Medical Society. The Florida Area Health Education Center Network is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Florida Area Health Education Center Network designates this live activity for a maximum of 5 AMA PRA Category 1 credits, 1 credit per session. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Everglades Area Health Education Center, provider number 50-3066, approves this program for a maximum of 5 contact hours, 1 contact hour per session of continuing education credit through the Florida Board of Nursing, the Florida Board of Dentistry, the Florida Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and the Florida Council of Dietetics and Nutrition. Before we get started, I would like you to hear a little information about our medical society and our programs in the community. Most of these initiatives were made possible by grants and donations to our organization. We also have several gift cards that will be given out to attending pre-registrants by random number selection on the first live broadcast of this webinar. And at the end of the session, please scan the QR code or follow the link provided for the required assessment for your education credit. For those viewing live, the assessment will load immediately at the end of the session. Thank you again, and please enjoy this education session.
Hello, my name is Dr. Tiffany McCullough. I am a board-certified emergency medicine physician as well as a wellness physician. I am currently the board president for T. Leroy Jefferson Medical Society for the term 2020 through 2022. I'm honored to be here. T. Leroy Jefferson is made up of healthcare professionals dedicated to improving health and wellness, access to care, academic and career development, as well as being sure to create additional opportunities for the underserved community. With opioid deaths on the rise across all racial and ethnic groups, our society has elected to educate the provider community on opioid-related issues because, truthfully, a project like this aligns perfectly with our mission. This is a 5-part series, and it is made possible through a grant from the Health Council of Southeast Florida. According to the Centers for Disease Control, nearly 500,000 people, that's 500,000 people, died from overdoses involving any opioid. This includes prescription medication as well as illicit opioids. In recent years, nearly all racial and ethnic groups are affected, and everyone has really experienced a significant increase in opioid-involved related deaths. That includes synthetic opioids and manufactured opioids. With our overarching goal to save lives, we plan to educate medical providers to give them a comprehensive and holistic approach to teaching patients with acute and chronic pain. We aim to help providers. We are using a 5-pronged solution. These measures include improving their clinical decision-making, helping to enhance their patient management strategies, helping physicians interpret new clinically relevant findings, analyze health policy, and having access to resources for review. I'd like to thank you, our viewers, for electing to take this opportunity for additional learning. We would also like to thank our team for making this possible. We ask that you would fill out the brief survey at the end of this opportunity so that we can know how to best serve you in the future. A special thanks to the Health Council of Southeast Florida for making this project possible. If you would like to know more information about T. Leroy Jefferson Medical Society, please visit us at our website, which is tljmedicalsociety.org. Again, tljmedicalsociety.org.
I'm Sandy Collier, and joining us for this session is Dr. Brian Coleman, Orthopedic Surgeon. Dr. Coleman, thank you so much for being here with us. Let's start with, tell us a little bit about yourself and your practice.
Well, as you mentioned, I'm an orthopedic surgeon. I specialize in foot and ankle surgery. My practice is in Delray Beach primarily, and I've been practicing orthopedics for almost 30 years.
Wow. So let's talk a little bit about opioids in terms of surgery. As a surgeon, what training did you receive pertaining to prescribing opioids?
Well, Sandy, that's part of the challenges we have today is we really back in the 1980s and 90s and even in the 2000s, we had no formal training with regards to prescribing opioids and how to utilize them and what to look for. It's sort of been a situation where we learn these things on the fly. What I mean by that is when we were in our early years of training, there was aggressive marketing by pharmaceutical companies, and all you hear about were the great things that comes with opioid use. You didn't hear about the addictive properties and the nightmares that come as a result of that. Even for our organization, the American Academy of Orthopedic Surgeons, there was a large emphasis 20, 30 years ago placed on pain assessment and the importance of that and understanding the pain that the patients are in. Understand that the whole foundation of practicing as an orthopedic surgeon is based on pain that a patient has. So obviously, understanding the pain, if it's legit, how to manage it, is a fundamental tenet of how we practice on a day-to-day, week-to-week basis. In addition, there was a growing fear that the traditional non-steroidal anti-inflammatory medications that we utilize so regularly, and it actually was pretty much our go-to medication, there was some literature out there that spoke to anti-inflammatory medication having a negative impact on fracture and bone healing. So with this belief from the literature we were presented, along with the emphasis on opioid use, it was a perfect storm to increase opioid use as a regular practice and treatment plan. What we've learned now is that those studies that basically said traditional non-steroidals negatively impacted bone healing are not really true. They were primarily sent out by the pharmaceutical companies in an attempt to promote the opioids. That's what we're finding out now. We now understand that those studies had flaws with regards to number of patients, how long they were trialed in these particular articles. And now that belief is not really something we adhere to in our practice.
So, doctor, what are some alternative treatments to opioid prescriptions?
That's an excellent question, Sandy. When we see patients, we have certain clinical cues, I call them. Buzz phrases like the patient says, I have a high pain tolerance. Only certain narcotics work. They get into specifics on the dosage. Those are things in the history portion that we look at that give us pause with regards to this patient potentially being an abuser of opiates. So there's other things like a history of anxiety, depression, benzodiazepine use, chronic pain, and of course, obviously a history of prior substance abuse, them seeing a pain specialist for management, and a lot of times the patient will display an agitated or anxious behavior, inconsistent physical exam. These are the things, at least in the initial interaction, we look for. So as you're getting a history, as you're formulating a diagnosis, and as you're putting together a reasonable treatment plan, you have to factor in how the patient's issues will be managed. Typically, for me, the lead hand is if they are a surgical candidate, which we will speak of today, what the level of surgery they're going to have, meaning that is it something that's going to require an inpatient stay, the length of time, the amount of soft tissue and bony damage that will be implemented as a result of me fixing whatever needs to be fixed intraoperatively. So once you factor in the surgical execution piece, then you have an idea about what tier the patient falls in terms of how much pain they would require, or pain medication they would require. Typically, for any medium or major level of surgery, preoperatively, I will lay out in detail my post-op management pain to the patient so they understand at 1 week, at 2 week, at 3 week, at 6 week, at 10 week, exactly what they'll get from me. So you already create a mindset of you're going to be boxed in regards to what I feel you need and what you should have. Now, obviously there are exceptions. Any postoperative complications, obviously you take into account the subjectivity of the patient, understanding what the history is. You know there are probably those that have been on pain management and have been on medications, whether it's opiates or benzodiazepines. You understand from your experience that they're also going to require at longer than the average patient that is not. It's in those instances where I will implement, even though it's an opiate, it's less potent tramadol medication in 6 weeks, where I might not in other cases. I will start having a conversation about anti-inflammatories, topical medications, lidoderm patches. Then we have a whole armamentarium of physical therapy modalities, whether it's heat or cold, massage, electric stim, phonophoresis, ionophoresis, TENS unit. All those things can be implemented that are non-opioid methodologies that will help manage the pain for this patient. If this patient has a fairly significant history, I will immediately introduce, at some point, you may require a pain management specialist to intervene. That's typically how I approach these patients.
Wow. So what factors, whether physical, mental, or social, influence your decision when prescribing opioids to patients?
Well, again, as we had previously talked about, their history and having a previous usage is very significant. Because what we do know, that subsequent studies show, at least in the orthopedic field, that if patients have prior use of opioid use, and that if they have taken it over 12 weeks prior to seeing you or prior to the surgery, approximately 50% of all of those patients will be taking some level of opioids for the next 5 years.
Wow.
That's what we understand. So the history portion, their social behavior, whether they're a smoker or a social drinker daily, again, how they are displayed, what they dictate to you versus what you dictate to them. These are all things that are factored into those decisions.
Dr. Coleman, thank you so much for sharing all of that information with us. We have a lot of medical professionals listening to us right now. What advice do you have for them?
Well, I'll speak for my specialty. My advice is, we say it all the time, the history is very important. The nonverbal communication in that initial office visit is critical. Patients can tell you so much without talking to you. You can hear what they're saying, but if you look at what they're doing, there'll be subtle cues that oftentimes will tip you off on a patient that's at risk. And then, as I've previously stated, outlining in as much detail as possible your specific post-op regimen for the procedure you're proposing, I think gives everybody involved in the process a clear understanding of where you are with things. They have goals to commit to. You have restrictions and guidelines that you adhere to. And if things happen where the party goes outside those guidelines, then you offer very quickly and very early a pain management specialist to sort of take over that portion of your care.
Doctor, thank you so much for your service to our community. We'll see you next time.
Thank you.
And joining us for this session is Vance Johnson. You remember him. He is a former NFL wide receiver, and he's had a battle with opioids, and he's going to talk to us about his battle today. Mr. Johnson, thank you so much for being here. First of all, tell us about your first experience with opioids.
Well, let me say how excited I am to join you. I think this is just so important, especially during these times where we're able to get together, that we have these Zooms and these other ways to just really get the word out there and to continue to educate everyone. And so I'm blessed to be here to share my testimony with you and to offer hope and to share what's really important in my eyes is how important doctors and physicians are, especially during this time where people are struggling and they can't reach out for help, but yet they have someone that cares a lot about them and that knows some ways to show them the way out of the darkness that they're living in. And that's these physicians and doctors. So to start a little bit of my story, before I get into how I really got involved with the opioids and different types of medications, I want to talk about where it all started. Now, when I was a child, to me, I grew up around a lot of trauma. My father was very abusive to my mother. He had a lot of affairs. There was a lot of addiction in my world as a kid. And so to try to get away from it, my job to me was to try to figure out how I was going to make something of myself, because what I grew up around, I didn't want to be like. So I started to just really think that my life and my identity had to be something I had to achieve. So what I did then was I started to watch and focus on sports and working really hard to try to make myself into something, thinking that somehow I would get away from the craziness that I had to grow up around, not knowing that emotionally I was struggling. So as time goes on, I get through junior high school and my sports doing really well. I get through high school. I'm one of the best in the world, actually. In fact, I go over and win the gold medal for the United States of America in the Pan American Games for Junior Olympics. And then all of a sudden I get drafted by the Denver Broncos, second pick in the second round. So I'm thinking to myself, I don't have any drugs in my system. I don't use any drugs. I'm not drinking. I'm not taking any pills. I'm not doing anything. I finally made it. So when I got to Denver, Colorado, I didn't know that once I started to try to cope and deal with things that were happening in my life at that time, that I was going to have to lean on different types of drugs and alcohol and relationships to try to cope with life. Well, it happened. And that's when I started to have injuries during my career. And I would see guys getting these shots. I would see guys taking these pills before the games and during the games. And I realized that those were something that I was going to have to start leaning on because of the injuries. And what I found out was when I took pills, I felt better. So, and, it was really traumatizing to me to know that whenever I wasn't on the football field, which that was only the edited version that people saw of me, when I was off the field, the only way I dealt with the injuries and I dealt with even my emotions was by taking these opioids to not only get away from the pain that I was feeling because of the injuries, but literally to deal with even the emotional and mental stuff that I was going through at the time, not realizing it was going to lead to an addiction.
So what was your lowest point? What would you say was your lowest point, and what would you say was your rock bottom point?
It took a lot of years for me to hit my lowest point because for some reason, being a successful, well-known athlete, people didn't see me as having a problem. And I didn't see myself as having a problem. That was for the people who didn't make it in life. To me, just because I was taking a whole bunch of opioids didn't mean that I wasn't a drug addict, if that makes any sense, And because when I met with doctors during that time with my injuries and the prescriptions that I was able to get, I was taking 15, 20 plus pills a day throughout my career. And even after my career, after 10 years and 3 Super Bowls, the pain didn't go away, not physically and not emotionally. And so I started to lean on those things even more. And that's also when I started taking antidepressants, sleeping medications. I was taking oxys, I was taking codeine and morphine, Vicodin, anything I can get my hands on just to get out of me because I didn't want to feel anymore. Not knowing that when I visited these doctors sometimes, what they would do because I was a famous athlete is just prescribe whatever I needed. Well, I ended up actually having a really serious problem with my addiction, and I almost died one time. In fact, I had an accidental, and I'm going to show, I don't think you can see it, but if anybody can see that injury on my arm, that was one of my accidental times trying to kill myself. And so I ended up actually ODing. They brought me back and told me, Vance, you may lose your arm because of what you've done to your arm. But I woke up, I continued to lean on addiction, to use. And finally, one day I called my mother. I was drinking and taking so many different pills and told her I was going to die. She raced over to pick me up and we went to the hospital. And by the time I got to the door there at the emergency room, I fell on the ground and literally fell into a coma. And so for 28 days, I was in a coma. And at day 24, after they took the respirators out of me, they ended up actually taking them out and watching me. It was my deathbed. And I have a deathbed picture. I'd love to send it to you so you can share that so people can see I'm not just an athlete sitting here trying to inspire people. I'm sitting here using my transformation to help, my transparency rather, to help somebody with their transformation. So I hit rock bottom because I was only coping and dealing with the pain that I went through by using.
Wow. So this is so fascinating, and I gotta thank you again for sharing with everybody who's here. At what point did you say enough is enough? I can't do this anymore. At what point did that light, went off in your head for you?
What's really, really interesting is I ended up actually relapsing after I left the hospital from being in that coma. And I met a doctor who, for some reason, this doctor would not give me any more drugs. I wanted opioids so I can cope with what I was dealing with, because to me, I felt like that would make me feel better. But he kept saying no. And I was like, well, dude, what are you talking about, man? I've got injuries from my NFL career. I need some pills so I can not feel what I'm going through. He actually, and this is what I want to share with the people that are watching this, because I know you have a lot of therapists and doctors and physicians that are watching this stream, that you are the key. And I know you care. And because it used to be the front lines with the cops, but for some reason now people don't want to trust cops. If not you, then who? It's a doctor who literally talked me into understanding that I was struggling with a lot more than just taking these pills and stuff, trying to figure out how I was going to get through my life. But it wasn't until I just was driving through a canyon one day and I was screaming and crying out to God, because I'm a man of faith. And I thank Dr. Mark Twardowski for 3 years keeping me off opioids. And then I leaned on different types of alcohol until I just cried out one day and just realized I had to go get help. And so I literally reached out to the NFL, and they paid for me to go to treatment because I was $1 million in debt. And when I went out to treatment, I started to learn about addiction. I started to learn that I was struggling with a lot of underlying issues. And that's what much of this generation, especially right now, is suffering with, is a lot of the trauma that they've gone up in life, and they're leaning on addictions. And so I want to encourage all the physicians that are watching right now to please use that gift that God gave you to save lives.
How long have you been clean?
I've been clean now for a little over 6.5 years, and I am just so blessed because now I know the whole reason I led the life that I led was so that I could be in this position and on this stream with you today to share hope and let people know that this is your testimony in this life. There's a gift that those doctors have to help save lives, and there's a gift that people that are in recovery have to go out and share their transparency, leading to not only their transformation, but somebody else's. And that's what I'm going to do. In fact, and I'm going to add this in there, I've recently been casted and asked to be one of the main interventionists on the show A&E Intervention.
Wow. Well, sir, I'm going to ask you, because every single one of us possibly knows somebody that has an addiction. And I personally know within my own family that, that's struggling, with addiction. What do you say? And I want you to speak directly to the person out there that's struggling with addiction, that does not think that they can get off of this. I want you to speak heartfully to them right now.
Well, first, I'm going to let those loved ones know something. You cannot love somebody out of their addiction. You can love them through it. I hope you got that. You can't love them out of the addiction, because all you're going to do is enable them, and you're going to keep on just giving them what you think they need to help them stop, but they're going to keep going because they can't by themselves get off of it. But you can love them through it. And so I'm going to encourage you to just be as transparent as possible with your loved one and let them know that when you hit rock bottom, I'm going to be here to help you. And that's the other reason why I'm in this space now, because I want people to either reach out to me if they need someone to do an intervention, reach out to me if I can even just talk to someone, share my testimony. I'm that transparent, and I'm not that famous guy anymore that I want to exalt myself. I want to keep myself humble so that I'm there to help people that might need a loved one to get into treatment. Also, if I may, I have a Vance Cares website where you can go onto, and we have a number of mental illness hospitals right there in Florida, about 4 or 5 of them, that we can help people that are dealing with dual diagnosis, especially when they're struggling with different types of opioids and any other type of addictions and underlying issues. But you need to just reach out. But those loved ones who have someone who's struggling, you can love them through it, but you can't love them out of it. And if you are suffering with an addiction, I need you to reach out for help.
Sir, one of your Arizona Wildcat friends, international player Morgan Taylor, said he is so proud of you. and to keep up the good work, and he'll see you soon.
Oh my gosh, thank you so much for that, because you know what's really strange? I thought I was better than everybody else when I was at college and even when I was in the NFL. And I'm just so thankful that guys like him were just continuing to pray for me and that are watching my story right now just play itself out. And so let me first say to them, I'm so sorry that I was a selfish, self-exhausted son of a gun. I don't cuss anymore. I sure appreciate your support, guys. I love you guys so much. It's about team.
Thank you so much, Mr. Johnson. You have been an inspiration to all of us, and thank you so much for sharing your story. I can't thank you enough.
I thank Jesus Christ for everything he's done for me, and I thank you guys for allowing me to be on your stream today.
I'm Sandy Collier, and thank you all for joining us.
Hello, my name is Dr. Carl Michel. I'm a foot and ankle surgeon and current board member serving as parliamentarian and health education chair of the T. Leroy Jefferson Medical Society. Thank you for taking part in this opioid prevention education series. This 5-part series was made possible through a grant from the Health Council of Southeast Florida. We hope this series helped you to improve your clinical decision making, enhance your patient management strategies, interpret new clinical relevant findings, analyze health policies, and gain access to resources for review. On behalf of our organization, we would like to thank you for electing to take this opportunity to learn. We'd also like to thank our team, and especially the Health Council of Southeast Florida, for helping to make this project possible. For more information on T. Leroy Jefferson Medical Society and how to become a member, please visit our website at tljmedicalsociety.org. That's tljmedicalsociety.org. We would love to have you. Thank you.
Joining us, Dr. Coleman and Vance. We have lots of questions for you guys tonight. So let's start with Dr. Coleman. Dr. Coleman, has there ever been a time when you had to deviate from the post-operative plan that you had previously shared with the patient before a surgery? And what are those factors that allow you to make those changes?
Thank you very much. And again, it's great seeing you all. And Mr. Johnson is extremely inspiring presentation. And I'm just so proud of you and blessed to have this opportunity to be with you guys today. So Sandy, yes, in a word, you'd like to dictate and outline the entire post-surgical plan in the preoperative visit, and I always have a pre-op visit that is solely to script walking the patient through the significant time afterwards, which includes pain management the pain management regimen. And what I will say is sometimes intraoperatively things are a little more difficult. Your procedure is harder due to increased bone production if you're removing hardware, or you're dealing with a very complex deformity and you have to just do a lot more surgery. So it's at that point where you're in your mind thinking, this patient is going to hurt a little more than what they may anticipate. And so you have already, well, at least I have already programmed in my mind that they may require pain medication longer, and it may warrant a modification of our post-operative plan that was previously discussed. Typically, I typically see patients once a week for the first 3 weeks, so I'll communicate that to them. So again, it will be known that this was more difficult, and it may have a little prolonged pain than what we originally thought. The other factor that you can't anticipate but can sometimes happen, as you know, every surgery has complications and risks as a result that can lead to negative effects. What I mean is wound healing problems and infection and things like that that can lead to increased pain or increased immobilization. And then when the patient starts therapy, they're actually loading the area and can cause more pain than was originally anticipated. And it's at that juncture where you will extend the stronger medications to cover that level of pain post-operatively.
So, and you started to touch on this, so I'll go right into this next question. Since nearly all of your new patients complain of pain of some sort, how do you determine what pain medication and regimen to implement?
Well, in an orthopedist's life, when a patient presents with the common complaint of pain, which is why they're seeing you in the first place, you have to discern whether or not they're going to be non-operative treatment, at least initially, or whether they've exhausted all reasonable non-operative treatment, and it's looking more likely than not that they're going to require surgery. So when you put patients in the non-operative category, you try not to manage whatever pain they have by any narcotics, at least I don't. Because if they started, it's going to be if they've come in and are already on pain meds, as previously stated, it's going to be a problem anyway, getting them off. And if it's for over 6 months, then I will, in my mind, engage a pain management specialist to help manage the pain, the patient's pain and problems very, very early in the program. When a patient is dealing with non-operative when they're deemed non-operative and you are dealing with a problem that doesn't necessarily require surgery at the beginning, you try to stay away from any narcotics because you would actually be contributing to a potentially addictive situation, which is definitely something you don't want to do. So if the patient is looking like surgery, I will try non-operative treatment and some other management that says if you fail this, then it's most likely you're going to need surgery, and that's when we talk about the post-surgical regimen. So it's really putting the patient in two different categories almost immediately: non-operative treatment, no narcotics; operative treatment, a discussed post-operative management regimen.
So, Dr. Coleman, this next question, I'm interested to hear how you would answer this as well, because we know there are a lot of patients that go out there and they're doctor shopping. Are there ways to combat doctor shopping, and if so, can you talk a little bit about that?
Well, there's two doctor shoppers. There's one doctor shopper that has no problem with letting you know they've seen other physicians, and sometimes in their dialogue they'll mention 3 or 4 different physicians that they've seen in a very short period of time, maybe over the last 6 to 9 weeks, and that's automatically a red flag, particularly if the disciplines that they're describing are musculoskeletal. Even if it's 2 or 3 orthopods, 2 or 3 orthopedic surgeons with the pain management specialist. Anytime a person mentions a pain management specialist, you already know, or you can assume reasonably, that they're going to have a problem, and you're going to have a problem with managing the patient, whether it's operative or non-operative. So you have to factor that in. In fact, if a patient mentions to me that they're seeing a pain management specialist, then I will defer exclusively to that person. Now, you may hear things like, well, they don't want to see me for 6 weeks and I need something now. And that is very, very common, and it can be a ploy. I mean, and sometimes, and I understand it's addiction, so this is not judging. these are just some of the things I'm trying to communicate. Oftentimes, folks will go to the extreme that they'll find out when you're not on call, when they visit you and you said no, and if you have partners, they'll wait till the partners are on call, and then they'll actually talk to them because they know they don't really know them. Policies now are instituted with multi-physician disciplines that after certain hours, no narcotics are renewed, which sort of forces the patient to seek other alternatives to pain management at that time. So if you've been around long enough, you kind of know the tricks. You do understand that, sometimes, particularly in a chronic problem, particularly in the orthopedic realm, it's gonna require some level of pain management, but if it's narcotics, then you automatically know that that person is gonna have a problem, and you just have to be mindful of that and help them navigate through that process.
So, talking about doctor shopping, how early should healthcare professionals be educated on opioids? Does it start in college or during nursing, medical school, pharmacy school? What do you think we should be doing in terms of educating healthcare professionals on opioids?
Well, it's shifted because before we didn't really have a targeted education platform on opioid use. I've been around for 30 years, and there was no dialogue, college, med school, other than study them in pharmacology, or certainly in a clinical practice, where you had specific dialogue geared to addressing and dealing with opioid use, which, honestly has contributed to this, okay? Because before, and at least early in our career, I think, as I stated, we really didn't understand the negative ramifications of prolonged opioid use. And when you are a physician, your passion is to make someone feel better. And as Mr. Johnson stated, he just wanted to feel better. And at the end of the day, a humanistic side of you says, I want to help you feel better. So when you're not educated or you're not exposed to those potential problems, then you're sort of dealing in a space that you are dealing in a space of a good heart, from a good place, wanting someone to feel better. What you're not really realizing now we do is that we're really enabling and contributing to a problem. So it's really hard as a physician to say no and I don't know and those kinds of things, because you're looked at to be a solution. So if you are doing things that is not helping an individual, you feel like inherently you may be failing the patient, and that is factored in as well.
Thank you so much, Dr. Coleman. Boy, Mr. Johnson, you definitely, I enjoyed the interview that I did with you. I learned so much about the struggle that people are going through. So let's talk a little bit about what are some of the things that family members of the person that is struggling to overcome this, how do you show them their love? What do you do? Let's talk about that.
Okay. Well, first I want to thank, am I coming up on video? Can you see me?
Yes.
Okay. I want to thank Dr. Coleman, because that was just so powerful, brother. I mean, you literally was explaining everything that was going on with me and how I just wanted the pain to go away and I wanted to feel better. So thank you for letting me know that back then there weren't a lot of studies and that doctors were just trying to take away the pain. And so it really makes it apparent now that we just have to really go out there and continue to educate. And you talked about educating. I think colleges will be a really important place to start. I spoke at colleges this month to some young students who were looking to be doctors. They were osteopath doctors here in Kansas City. So I think it's going to be a really empowering thing to start educating young people that are looking to become surgeons and different types of doctors and physicians, to let them know that opioid is a really big issue these days and how people are taking drugs just to try to feel better. And unfortunately, it's leading towards a lot of the ODs that we're having. So again, I'll ask that question again so I can answer it. I was just so excited listening to you.
Yes, Dr. Coleman. Dr. Coleman is very, very knowledgeable. I can listen to him all day long. What are some things that family members of the person that is addicted can do to show love through their addiction? And do you think healthcare professionals can do the same thing?
Absolutely. And as far as family members, I think I mentioned before how family members, you can't love a loved one out of an addiction, but you can love them through it. And many times when a family member ends up losing a job or their relationship or something, and they end up having to move back home with you, a lot of moms, dads, or whoever it is that you're living with will enable you by trying to give you money so that you can survive because you're trying to figure out how to get back on your feet. Unfortunately, that is causing people to use those monies to go out and buy drugs. Then you have some family members who won't allow you to have any monies when you're in your home, but other family members who aren't living there with you provide you with resources, which also causes you to go out there and buy drugs secondhand. So I would just really want to encourage the loved ones who have family members who may be struggling with opioids or any other type of drug use to just, it's almost like doing an intervention. You need to tell that loved one, listen, I want you to get help. I'm going to be here for you, and you're welcome to live with me as long as you make a commitment that you'll go out and get some help with the problem that you're having right now. And really just talk a lot about what's happening and ask your loved one to be transparent about it. And then, there are doctors out there who, in the past, they were just trying to take away the pain. And that's how it is with athletes, especially. We just want the pain to go away. So I'm glad that doctors are being more educated now and knowing that the opioids are causing a lot of people to end up ODing and causing a lot of death. So there's a lot to be done by doctors making sure that they find out and look at that patient, like the doctor mentioned, to see what types of habits they're doing, see if they're asking for different types of opioids, how much they want to take, and to know that it's going to lead to something that could possibly cause an addiction and eventually death. I had so many different operations, I had so many different problems, that I'm just really glad that doctors are wanting to be more involved now to find out about underlying issues, about the injuries themselves, and about how it's going to affect long term if someone starts to take opioids.
So, talking about doctors, do you think some doctors cross the ethical line because they're dealing with celebrities and wealthy patients? And if so, what do you think as a person recovering? How do you think that should be dealt with?
Well, that's a very good question, and so that's the reason why I'm really excited about partnering with you guys, because I think we can go around and really share a lot with professional teams, because a lot of doctors are just looking at taking away the pain so the athlete can go back out in the field to participate in the game. And unfortunately, because like the doctor mentioned, they weren't educated in the past. They were just giving you whatever it took to take the pain away, not realizing that after 3, 4, 5, 10 years of your career, if you're taking opioids to try to survive, that in the long term, it's something that's going to cause you to have not only a lot of pain, but eventually either you're going to be using, and it can cause a lot of death. Because a lot of former professional football players OD with opioids, but they don't talk about that. And so I think it's really something that we need to continue to go out and educate people about, and especially doctors who are, prescribing these opioids to athletes during their career so they can just get back on the field and play. And I think a lot of it has to do with the fame. A lot of it has to do with you have a game this weekend, and so even though you have an injury, they just want to take the pain away. So we have to continue to educate people. And I have some friends within the NFL that hopefully we can maybe partner and start just really setting up meetings so we can talk to the doctors a little bit more about educating these young men about what's going to happen possibly long term with these injuries and the types of drugs they're having to take to go out and participate.
Let's talk a little bit about, when you sit down and you first talk to someone who is struggling, what is that conversation like with you and that individual, being that you are recovering yourself? How do you have that conversation with someone who's struggling and who really just is blaming the whole world, or saying, well, this cost me to do this and that cost me to do that, and they aren't taking, they can't seem to have any hope when they're sitting down and talking to you? How does that talk? Let's talk about that.
I talk to a lot of people all over the country, especially when I'm doing interventions, and now because of the COVID-19, I'm not able to really travel around the country very much to meet with anyone personally. So I do a lot of phone call conversations, and I just really want to dig into kind of underlying issues and why people feel like they need those types of drugs to cope with what they're dealing with. And many people say it's just a crutch, and I'm like, I need you to think about that word crutch in a different way. And this just happened just a couple days ago with an individual while that I'm trying to help get back into treatment because he ended up relapsing after finding out, and he's not listening to the show, obviously. He found out that some things happened while he was in treatment the first time. His wife had an affair on him. I had to say that. And he's having a really hard time. He ended up actually even getting fired. And even before he got fired, before he found out these things that was happening with his wife while he was in treatment, I was trying to explain to him how he should go to that next level of care after you get treatment. But unfortunately, he kept saying, well, you know, it's my crutch to lean on drugs. And I said, actually, it's not a crutch, because a crutch is something to help you get up, not to go down to your grave. So you need to look at that in a different way. And he really wants to get the help and get back into treatment now. And so when I talk to someone, you have to just be really transparent, and you can't try to love them into treatment. You have to just really get to the underlying issues and find out if they've had injuries and if they've had some trauma that they've gone through and the things that they're dealing with, to try to figure out what's going to be the best way to talk this person into getting into treatment. So luckily, I've been talking to just people all over the country, and they're really being transparent and open about what they're going through, because I've opened myself up too about what I've gone through to try to encourage people to get help. And then I tell people another thing. You have to understand that this pandemic, and with the epidemic, with the overdoses and the people dying, that the things that you're struggling with right now is something that I really believe that you can use, especially if you end up getting help, to offer hope to other people who are struggling. And I think that's another thing. So I try not to judge people who are suffering, who are dealing with these different addictions, but try to really encourage them that they can use what they're struggling with to get help, so they can go out there and be an offer of hope to somebody else that's struggling. Because this country is really struggling right now.
We've got a lot of issues right now. Let's talk a little bit about your faith and how your faith has helped you to fight your addiction. Talk about that a little bit.
I appreciate you bringing that up, because I always got to talk about my faith, because, you know, growing up, like I had talked about earlier, and growing up around a lot of trauma and thinking that I had to achieve to have my identity rather than receiving an identity, it took me a mighty fall down, and everyone saw the photo of me in the coma, for me to be broken enough that I could just cry out to this God that I knew I believed in all along, and thinking somehow that if God was real, he was going to help me get out of this problem that I had with the suffering mentally, and then with the addictions that I suffered with, literally wanting to kill myself, ODing actually. And they didn't use the word OD back then, they kind of used some different words back then, but I OD'd a couple back in the past. So when I cried out to God, and I had people reach out to me, one of my ex-wives reached out to me, and the NFL to offer to make the payments to get me into treatment, because I was $1 million in debt. That when I went to treatment, I just really leaned on my faith, and I also leaned on getting educated about this problem. And I started realizing that God had a plan for me, and that was to use this mighty fall to my deathbed, strip everything away from me, because I really lived a life that to me was about fame and fortune and stuff and relationships to make me feel good, that wasn't going to do anything for me except for set me up for a mighty fall. And so after I started reading my Bible, and you know what, let me share something with you real quick. Do you know that starting even in Genesis, it talks about the gift of doctors? And even one of the apostles, the apostle Luke, was a doctor as well. So you physicians, you have a God-given gift to go save lives. Many of us try to use these gifts to make ourselves successful, but really our gifts are so that we can offer hope to people who are struggling. And so I almost envy doctors, because you've been giving such an amazing gift, because there aren't very many of you out there that have the gifts that you have to care enough about people that you can help save their lives. So I'm going all over the place right now, so I appreciate you.
No, that's wonderful. That's wonderful. Can you just show us in the video, can one of the participants wanted you to just show us your arm again, that you said that you almost cut that arm off when you was struggling.
Yeah, again.
Can you show us a picture of that?
Oh yeah, I'm gonna show that to you. I was so suicidal when I was playing football. I even tried to kill myself actually right after one of the Super Bowls. And then after my career was over with, I wanted to die in any way that I could, whether it was gonna be a car accident, whether it was about shooting myself, or even cutting myself. And this was one of my accidental, if you can see that.
Yeah, wow.
That was one of my accidental times trying to kill myself. I ended up going to a hospital after that happened, and I passed out, and they ended up bringing me back because I had OD'd. and the doctor told me that I might be losing my arm after I woke up. And so 2 weeks later, when I woke up, my arm was filleted, and they had all different types of things that were in my body. And even after I left the hospital, I still had to lean back on the addiction to try to cope and deal with the things, the underlying issues that I was coping with, until it got to a point where Dr. Mark Twardowski told me, he's not going to give me any more opioids. And then he wanted to know a little bit more about my history, and he started seeing how I had a serious problem. So he kept me alive long enough for me to hit rock bottom, but still be able to get on the airplane and head out for treatment in Florida, right in West Palm Beach.
Wow. Well, thank you so much. It just listening to you is so inspiring, and I can't thank you enough for sharing everything that you're sharing with us, because there are so many people out there that needs to hear this, and so many people that are struggling and they need help. So we really appreciate you just joining with us and teaming up with us to get the message out there so we can combat this problem once and for all. I think we have a quick question here for Dr. Coleman. Dr. Coleman, if you can answer this question in about 30 seconds, that will be wonderful. How do you address patients with prolonged opioid use?
I address them by asking them if they've ever had assistance by a pain management specialist. If the answer is yes, and the patient and the doc is local, I will reach out to them immediately, let them know what the diagnosis is, what my treatment protocol is going to be, and would you please assist me in managing the patient. If they don't, I have an armamentarium of physicians that can help facilitate joint care for the patient.
Well, thank you very much, Dr. Coleman. A special thanks to all of our panelists for participating in this series. This is such an important topic, and we must continue the conversation to bring change and promote healing for those struggling with substance abuse disorder. A special thank you to Dr. Carl Michel, our health education chair, for all of his hard work, and the entire team here at the T. Leroy Jefferson Medical Society. I am your host, Sandy Collier. Please take care of yourself as we continue to take care of each other moving forward. Thank you guys so much for being here, and please don't forget to fill out your your education credits at the end of this survey. Again, thank you to everybody. Thank you.